Good morning, everyone. This morning we will be speaking about a very common presentation of patients in the emergency room, and that's dyspnea. Now, dyspnea is such a huge topic. It encompasses a wide variety of conditions, not only respiratory, but it also encompasses cardiac, metabolic, renal, lots of lots of systems. That is not the aim of our talk this morning. Our aim is to see how an emergency room physician should be approaching a patient who comes into the emergency room complaining of difficulty in breathing, and how he or she should be dealing with the patient. So dyspnea is a perception of an inability to breathe comfortably, and it is a common chief complaint among emergency room patients. And like we mentioned, it can be caused by a lot of abnormalities that affects the upper airways, the lungs, the heart, the chest wall, anything at all the way up to the diaphragm and the nervous system. Now, the most common diagnosis that we need to remember among older patients presenting in the emergency room with a complaint of acute shortness of breath and manifesting signs of respiratory distress are uh, first, a decompensated heart failure, and second, pulmonary causes like pneumonia, COPD, in acute exacerbation, a pulmonary embolism, and asthma. The signs of distress usually would mean that the patient is tachypnic, with a respiratory rate of more than 25 per minute and an oxygen saturation of less than 93%. So initially, when presented with a patient in the emergency room, the doctor, the ER physician, should be able to perform a very rapid assessment as to what is wrong with the patient, looking for, first and foremost, signs that a respiratory arrest might be imminent or there is significant respiratory distress. And the signs that would mean that the patient might go into respiratory arrest anytime will first be his mental status. The patient will be obtunded. He will have a depressed mental status. There is inability to maintain a good respiratory effort, and because of this, the patient will be cyanotic. What are the other signs that would suggest severe respiratory distress, not necessarily impending respiratory failure? First, look for use of accessory muscles of respiration, retractions that you can see up in the suprasternal notch, or subcostal retractions, or intercostal retractions. You can see this usually among elderly individuals, and you can see this among children. This suggests an extreme respiratory distress, fatigue of the respiratory muscle, and a potential for respiratory failure. However, not all patients, even if they are going into severe respiratory distress, not all of them will present with retractions and use of accessory muscles. We must remember that there are patients who have neuromuscular diseases, and these kinds of patients, you may not see the retractions. And how about his speech? These patients will not be able to speak in complete sentences. There will be brief, fragmented speech. Um, the respiratory rate will be more than 25 per minute. However, that is not an absolute number. You can have a respiratory rate of more than 20, and you should promptly you should promptly evaluate these patients. And many of these patients will not be able to lie flat in bed. They either are seated upright, or they assume what we call the tripod position. There is an exception, which is the hepatopulmonary syndrome, in which the patient usually breathes more comfortably when they are lying down. What are the other signs that you should be watching out for when you are faced with these patients? Look for signs of diaphoresis. This reflects extreme sympathetic stimulation associated with severe disease like a myocardial infarction or a severe asthmatic attack or a severe diastolic cardiac dysfunction. There will be audible stridor or wheezing. This means that you did not even use your stethoscope and you can already hear the wheezes. And this can represent an upper airway obstruction or very severe bronchospasm. The skin will be dusky, which indicates pure perfusion or cyanosis. And although this patient may still not be um, mentally depressed, there will be agitation, they will be restless. And this suggests severe hypoxia or hypercarbia. When you are dealing with a patient who is already having a depressed mental status, meaning the patient is already obtunded, most likely this is coming from a carbon dioxide retention, CO2 retention, and the patient may look quite comfortable and he doesn't care about what's happening. So, when you are facing these patients who are in severe distress, how are you supposed to approach and how are you supposed to manage them? The primary goal for the emergency room physician will be first to optimize arterial oxygenation. Second, determine whether there is a need for emergency airway management and for ventilatory support. And third, to establish the most likely cause of dyspnea, initiate treatment, and stabilize the patient if they are critically ill. In a patient where the vital signs are abnormal and the danger signs are present, we need to first perform an assessment regarding the airway patency and whether this patient will be requiring ventilatory support. And we need to rapidly search for reversible causes like a tension pneumothorax that will be very easily diagnosed and you can easily reverse the at least for the time being what is causing all the symptoms. A pericardial tamponade as well, and when you have an obstruction of the upper airway because of a foreign body, provide supplemental oxygen, establish IV access, obtain blood for laboratory measurement, place on your cardiac monitor and pulse oximetry, and especially with the advent of this pandemic, maintain appropriate infection control measures. Regarding supplemental oxygenation, usually we deliver the highest oxygen we can deliver via a non-rebreather mask. We can deliver as much as 50 to 60 liters per minute. And how do we achieve this? You just open the flow meter valve until the indicator lies well beyond the 15 liters per minute mark. And all the while you are giving this high flow of oxygen, watch over your pulse oximetry because an SpO2 of 94% is usually an appropriate target for most of the patients. We need to remember that patients who are breathing 100% of oxygen will deliver 5 times as much oxygen to the alveoli per unit of ventilation than those who are breathing room air. However, even the best of our non-rebreather system can only provide as high as 85% of oxygen. Now, once there is it has been determined that your patient will require endotracheal intubation, higher levels of oxygenation are necessary because you need to increase the oxygen reserves of this patient in order to prepare them for intubation. There will be a period of apnea during that time, especially when you try to do rapid sequence intubation. Now, we have most of the patients who come with acute dyspnea should receive supplemental oxygen. However, there are certain patients who have normal oxygen saturation and normal vital signs, and they may not need supplemental oxygen. The supplemental oxygen, when you start them, can be started as low as 2 liters per minute via nasal cannula. Remember to target an oxygen saturation of 94 to 98%. Now, this is something that we are always afraid of in the emergency room when we are faced with a patient with these chronic lungers, COPD patients, and patients who come in with acute coronary syndrome. COPD patients, we know, have a very low threshold for their ventilatory drive. However, when faced with a severely dyspneic patient with COPD, even if you know that a patient has COPD, you see all the signs, the clubbing of the digits and the pectus, and you see all that. Do not withhold oxygen from patients with COPD. You just need to lower the target saturation to 90 to 94 instead of getting up to higher than 94%. And you need to keep in mind that even if you do target this low oxygen saturation, 90 to 94%, it can still reduce the ventilatory drive of your COPD patient and cause him to retain CO2. However, if you fail to oxygenate the patient, this may have more profound adverse consequences than the hypercarbia. Once you have decided that your COPD patient requires endotracheal intubation, your oxygenation should be maximized. Don't without regard for any kind of oxygen target oxygen saturation. For patients who come in with acute coronary syndrome, excessive oxygenation can be more harmful in those patients with acute coronary syndrome. So you administer oxygen only when the oxygen saturation is consistently below 94%. Excuse the busy slide. There, aside from giving the oxygen through our non-rebreather system, there are other means of providing oxygenation and ventilatory support. One of them is the high-flow nasal cannula, which can provide a relatively high fraction of inspired oxygen to the patient with severe non-hypercapnic hypoxemic respiratory failure. And this has been popularized more during the pandemic season. Um, Non-invasive ventilation is another means by which we can support the ventilation of our patients through the use of the CPAP and through use of the BiPAP. And usually this is accomplished with the use of a mask and is best for patients who come in with a decompensated heart failure or patients who are in exacerbations of their COPDs. Of course, endotracheal intubation and mechanical ventilation. When you have decided that the non-invasive ventilation is no longer improving the outcome of your patient, then you should go ahead and do the mechanical ventilation and intubate your patient. ECMO is again something that we have heard during the early part of the pandemic season, extracorporeal membrane oxygenation. Not all centers have the ECMO available, but if it's available, then it's one of the other alternatives that we can use. Now, actually giving oxygen to your patient can give you a clue as to what might be wrong with the patient, depending on how they respond to the oxygen that you have given. If you have given low flow oxygen to the patient and you see an immediate improvement in the O2 saturation, most likely you were dealing with somebody who has a VQ mismatch, like pulmonary embolism, for example. And for somebody who responded very rapidly to bronchodilators, then most likely you're dealing with somebody who had bronchoconstriction, like in asthma. If no matter how high the oxygenation is being given, the patient still fails to improve, then think about a right to left shunt or the presence of methemoglobinemia. And the other thing, the final clue is for patients who have HIV and they have infection with the pneumocystis carinii. Usually these patients, whenever they start to ambulate, it's very, very rapid for them to see a drop in their oxygen saturation. So once you have started the oxygenation, the other general measures that needs to be done will be starting the IV access, placing the patient on continuous cardiac and pulse oximetry monitoring, um, air management equipments in case you need to intubate your patient and have the respiratory therapist beside you, and continue doing your focus history and your examination and assess for a potentially difficult airway and search for rapidly reversible causes. You have to remember that the initial decision to provide either a non-invasive or an invasive ventilatory support is based upon clinical grounds and not upon laboratory values. Other things you need to do is to get an EKG done, get a portable chest X-ray. Um, this will be very effective, the ultrasound, bedside ultrasound, if you have highly trained emergency room physicians who can rapidly identify conditions like pericardial effusions or pulmonary edema or clinically significant pneumothorax. But this is very operator dependent and it depends on the experience of the emergency room physician. And of course, you need to optimize the hemodynamics of the patient, control the rate and rhythm if you have tachyarrhythmias, improve your right ventricular filling pressures by giving IV fluids or by giving vasopressors. When volume overload is suspected, then you give your unloaders. This has always been emphasized in all emergency room. Maintain appropriate infection containing measures. If you are dealing with somebody who has tuberculosis or with COVID-19, you make sure that the appropriate infection control measures are being followed. Now, um, patients who have inadequate respiratory effort, this can occur from respiratory fatigue. Examples, patients who are asthmatics or with COPDs, or those patients who already have a previous underlying neuromuscular disease. Um, you need to identify and monitor the impending hypercapnic respiratory failure. You might not necessarily have to do an arterial blood gas. A venous blood gas might be useful in the assessment of the patient presumed to be somnolent from CO2 retention. The partial pressure of carbon dioxide should be low in somebody who is hyperventilating. So if you see a partial pressure of CO2 that is normal or elevated in the setting of dyspnea and tachypnea, this usually means that the patient might be going into respiratory failure. Capnography is something that we can use to identify CO2 retention. We don't necessarily have to be very invasive. Capnography can be used and it can provide dynamic monitoring of the ventilatory status of the patient with acute respiratory distress by measuring the end tidal carbon dioxide and the respiratory rate with each breath. Capnography can provide instantaneous feedback, while trends enable the clinician to determine whether the ventilation is actually improving, worsening, or staying the same. Now, whenever possible, if you know the etiology of your respiratory distress, then initiate your management. Like for primary pulmonary diseases, you should be thinking about COPD, asthma, pneumonia. For sepsis, you should be thinking about severe sepsis that can cause respiratory compromise. And for all these things, whenever the patient is going into impending respiratory failure, do not hesitate. Always remember that you need to help the patient out with your work of breathing. So you need to decide whether you want to intubate and start on mechanical ventilation as part of the resuscitation process. Patients who come in with stroke do not usually present with dyspnea. Although, if the center of the brain um, is the one affected, the one that is near the respiratory centers, or if the injury is to such a magnitude that it can involve respiration, then you need to be wary of these cases. Such abnormalities may include aspiration pneumonia, neurogenic pulmonary edema, and various abnormal respiratory patterns, including apnea. And of course, patients who've got neuromuscular diseases, the patients who have um, multiple sclerosis or Guillain-Barré, myasthenia gravis. All these patients can have weakness of the respiratory muscle leading to respiratory failure. Botulism is another thing that we need to consider, causing generalized descending muscle weakness involving the respiratory muscles. Now, there are specific interventions that the ER physician should do once they find out um, based on the signs and symptoms of the patient. For example, a stridor. A patient who presents with stridor can either be coming in because of a foreign body obstruction, in which case the intervention will obviously be retrieval of the foreign body. If they have hereditary angioedema, then C1 inhibitors and bradykinin B2 receptor antagonist will be required. And those who come in because of anaphylaxis, in the patients, the ER physician should be ready with their epinephrines and their steroids and antihistamines. If on physical examination it's just a unilateral diminished breath sounds, be wary of the possibility of pneumothorax. And if it's tension pneumothorax, you need to be able to do needle decompression immediately, even before thoracostomy is performed. Same thing with massive pleural effusion or hemothorax. A thoracentesis might be able to help first before a thoracostomy can be done. Now, for patients who come in with crackles, withdrawals, um, if you're thinking about an acute cardiogenic pulmonary edema, then either do a non-invasive ventilation or you give your afterload unloaders. Um, COVID-19, this has been discussed before, doing awake pronation and high flow oxygen delivery system through nasal cannula prior to mechanical ventilation. And if an organophosphate poisoning is suspected, then empirical antidotal therapy with your atropine, your benzos, and your pralidoxime after endotracheal intubation. Now, there are signs and symptoms that might be with specific etiologies. For example, if you have patients coming in with hypoxia, however, you auscultated and the chest is clear, then think about pulmonary embolism, think about cardiac tamponade, think about methemoglobinemia. Presence of wheezes, asthma, and COPD. And for ECG changes, uh, think about your cardiac. So once you have initially stabilized the patient, now you are dealing with somebody who is on the stable side, and you can go ahead and slowly and surely take your history and do your physical examination, make it more complete now. So you need to, when you target the history, you need to look for events that led up to what the patient was feeling. Like, for example, somebody who already has heart failure before, if they were not compliant with their medicines, then they could become decompensated. Or if you found out that these patients decided not to follow the diet, started to take in more salt, or they decided to take in more water than the usual 750 to 1 liter that they're supposed to take every day, that could have caused the acute decompensation. Exposure to an allergen, think about your asthma. Um, Same thing when you have something that occurred immediately after a meal, think about an allergic reaction. So all of these things you need to think about. The other thing that you need to think about will be the onset of the occurrence of the dyspnea. There are many conditions that can cause an acute onset of dyspnea and many conditions that causes gradual onset of dyspnea. So this table lists the possible causes of an acute onset and gradual onset of dyspnea. When you perform your physical examination, you perform a more thorough physical examination after initially um, uh, screening the patient and you did the necessary stabilization. You need to remember that an unremarkable pulmonary and cardiac examination does not rule out a significant disease. For example, the sensitivity and specificity of pulmonary examinations are quite limited when you're making a diagnosis of pneumonia or acute decompensated heart failure. And this is actually quite true. When you're facing, this is one of the dilemmas in the emergency room. When you're faced with a patient who is acutely dyspneic, doesn't want to lie down, it is so difficult to determine whether you're dealing with something pulmonary or you're dealing with the heart failure. Are you going to nebulize this patient and are you going to aggravate his heart failure, or are you going to diurese this patient? This is usually a dilemma. So you what look out for the respiratory rate, the pulse oximetry, look for the breath sounds, whether there are striders, wheezers, crackles, and you look for the presence of abnormal heart sounds, irregular rhythm. You look for your S3 gallops, your S4, look for distant heart sounds, and you look at your jugulus venous. Uh, uh, you look at the jugular vein because you might have a jugular venous distension and also presence of pulsus paradoxus. So these tables will just give you some clues as to the physical examination finding and what are the possible diagnoses. Like if you have an absent or diminished breath sounds, think about pneumothorax or hemothorax. Use of accessory muscles, think about impending respiratory failure and severe COPDs or asthma. Your striders will depend on whether you have an inspiratory strider or a mixed inspiratory expiratory strider, to see whether you're dealing with a foreign body or you might be dealing with a crew. And somebody who's in hyperventilation doesn't necessarily have something in the lungs. It might just be because of salicylate poisoning, or because of acidosis, or because of anxiety. Now look at your your jugular veins. Somebody with a jugular venous distensions, however, with a clear breath sounds, might just have a right-sided heart failure. If you hear crackles, then think about involvement of the left side of the heart as well. Of course, heart murmurs, think about the valvular disease causing a valvular dysfunction. Pulsus paradoxus, you might think about the tamponade and the crackles and wheezes. Now, what kind of diagnostic testing should you be doing? In most emergency room patients with acute dyspnea, you should obtain a chest x-ray, you should obtain an electrocardiogram, you should obtain a complete blood count, and you should obtain serum chemistries. And then after that, going from there, after your history and your physical examination, that's when you start to direct your diagnosis to rule out specific illnesses. What about the routine use of dyspnea panels? These are biomarkers that include troponin, myoglobin, creatine kinase, D-dimer, and your BNPs. It has been found out that the routine use of dyspnea panels does not appear to improve the accuracy beyond clinical assessment and focused testing. And regarding arterial blood gases and multi-detected computed tomography scans, this should not be performed routinely and this should be reserved for specific circumstances. For example, regarding your arterial blood gas, this is something that was always being ordered in the past. When somebody comes in with dyspnea, automatically we ask for an arterial blood gas. But currently, there is a limited role in the diagnosis and treatment of an acutely um, dyspneic patient with the arterial blood gas. The decision to perform an intubation is based on clinical assessment. You do not base this on your arterial blood gas findings. Oxygenation can easily be assessed using your transcutaneous pulse oximetry, and your acid-base status can be assessed using venous blood gas and your serum bicarbonate. Now, if there are any concerns regarding the accuracy of the pulse oximetry, this is when an arterial blood gas should be requested for. And this just shows you where are the instances where arterial blood gases might come in handy. Like if there are skin pigmentations on the patient, somebody who is darkly colored, it will be probably better to measure the ABG so you can get a more accurate status of the oxygenation. This is something that I myself even just found out. Somebody who has a high glycated hemoglobin, somebody with high hemoglobin A1C values, it is not um, pulse oximetry can be affected by high hemoglobin A1C. It can actually give you a falsely normal or elevated oximetry reading. So it is recommended that somebody who's a diabetic and whose diabetes is not controlled and they have high hemoglobin A1C get a blood gas instead of relying on pulse oximetry. And another thing is somebody with the severe anemia. It will be more prudent to get the blood gases rather than relying on the pulse oximetry. So this just shows you how this is just a partial list. This is not by all means the total list of what you need to be thinking about when faced with somebody with an acute dyspnea. All these are the differential diagnosis of a patient who comes with an acute dyspnea. So when managing an acute dyspnea, there are pitfalls, and these are what needs to be avoided. First, failure to secure the airway in a timely manner. Failure to recognize the act and act on abnormal vital signs and signs of impending respiratory failure. Over reliance upon a single finding, either from the physical examination or from the test result, in order to establish a diagnosis. Failure to generate a proper differential diagnosis. Failure to consider carbon monoxide poisoning, methemoglobinemia, or um, pulmonary embolism. Misinterpreting tachypnea, which may not represent a respiratory abnormality and may reflect non-pulmonary disease, for example, a metabolic acidosis or an impending herniation of the brainstem, and allowing the patients with a tenuous respiratory status to leave the emergency room and deteriorate in the radiology suite or in the inpatient floor. And finally, discharging the patients without inadequate follow-up or with unclear instructions. So we need to watch out for all these things. Thank you.